Hi, I am Peter Glowicki from Mayo Clinic, editor-in-chief of the Journal of Vascular Surgery. The COVID-19 pandemic continues to affect millions of people worldwide. As we go to the press today on September 5, 2020, more than 26 million people in the world are infected with the virus and over 875,000 died. In the United States alone, over 6.2 million people tested positive and over 187,000 died. The COVID-19 collection of the JVS journals continue to grow, and it includes a large number of publications on how COVID-19 has affected our patients and changed our practice. I am pleased to introduce to you the November issue of JVS and highlight 4 outstanding papers which are freely available for the next 2 months. The CME article and editor's choice for this issue is entitled "Adverse Cardiac Events After Vascular Surgery Are Prevalent Despite Negative Results of Preoperative Stress Testing." This was written by Colombo and co-authors from Hanover, New Hampshire and Boston, Massachusetts. This retrospective review of the Vascular Study Group of New England database investigated adverse cardiac events and death in 26,910 patients who underwent common vascular procedures. The study investigated outcome of patients with negative tests and compared it with outcome of those who had no preoperative stress test. The use of stress tests across institutions ranged from 37 to 80%. Adverse events were not significantly different between groups who underwent carotid endarterectomy, BEVAR, or infrainguinal bypass. However, cardiac events or death were significantly more frequent in patients with a negative test than in those who had no tests at all after major vascular operation like a suprainguinal bypass or an open aortic aneurysm repair. This suggests that patients with a negative preoperative stress test retain a substantial likelihood of perioperative cardiac events. Our next highlighted article is on lumbar drain complications in patients undergoing fenestrated or branched endovascular aortic aneurysm repair, written by Dr. Alkame and colleagues from Worcester, Massachusetts. This retrospective study included 100 fenestrated and branched EVAR patients with an attempted lumbar drain placement. All drains were placed in awake patients with fluoroscopic guidance in 28%. The technical success was 98%, and 82% of the drains were left in place for 48 hours or longer. In 16%, the drains failed to maintain function. In 4%, they fractured or they were dislodged. Some patients, 9 patients, had leak around the drain. 4 patients complained of post-dural headache, and 17 had bleeding complications. These were asymptomatic in 11 patients, but 3 had intraventricular and 3 had subarachnoid bleeding. So the authors concluded that lumbar drains are frequently associated with non-functionality and complications, but long-term sequelae that are serious are rare. The next article by Sverdlov and co-authors from Boston, Massachusetts, New York, and Philadelphia, Pennsylvania, is on stroke rate after endovascular aortic intervention in the SVS Vascular Quality Initiative database. Stroke rate was 0.1% after EVAR. and aneurysm diameter greater than 6.5 centimeters and need for placement of a proximal extension cup were predictors of a stroke. Stroke rate was 0.9%, however, after complex EVAR that included fenestrated and branched EVAR and chimney EVARs, and the use of arm for access was a strong predictor of stroke. The highest stroke rate was noted in the group after TEVAR, 2.9%, especially if the proximal ending zone extended into the aortic arch. Involvement of the left subclavian artery with any procedure was a strong predictor of stroke. The final article highlighted this month is entitled External Validation of the Vascular Quality Initiative Prediction Model for Survival in No Option Chronic Limb-Threatening Ischemia Patients by Verweer and colleagues from Utrecht, the Netherlands, Worcester, Massachusetts, and San Francisco, California. This study validated 2-year mortality predictions based on outcome of a VQA cohort of over 38,000 patients who underwent intervention for chronic limb-threatening ischemia. The validation cohort included 150 CLTI patients who did not have an intervention. Interestingly, 2-year mortalities were similar. It was 21% in the validation cohort and 17% in the VQA prediction model. These results suggest that the VQI prediction model that is based on 12 preoperative covariates performed well, with a C-statistics of 0.86. That is the mark of a good model for predicting 2-year mortality risk in a no revascularization option CLTI population. These were just a few of the many excellent papers we published in the November issue of the JVS. Hope you will enjoy reading them. Please follow us on social media, and remember in this time of the pandemic to wear masks, wash your hands, and enforce social distancing to protect others and yourself from the coronavirus. Thank you for watching, and see you next time for the highlights of the December issue of the Journal of Vascular Surgery.